Hello everybody and welcome to our module on Wilson's disease and hemochromatosis. We'll start by talking about Wilson's disease. This is an autosomal recessive inherited disorder that involves the metabolism of copper, and I've put a picture of a penny on the screen here to remind you that copper is important in Wilson's disease. Copper is consumed in our diet. Many of the foods that we eat contain small amounts of copper and then absorbed into the body, and the liver is the important organ for metabolism of copper, and that's because the liver can do two important things with copper. First of all, the liver can excrete excess copper mostly into the bile. In addition, the liver can incorporate copper into a transport molecule called ceruloplasmin and then release ceruloplasmin into the serum where it will carry copper to other organs. Inside of hepatocyte cells, there is a very important protein called ATP7B. This is a hepatic copper transport protein. It has the letters ATP in it because it functions as an ATPase. And this protein can incorporate copper into ceruloplasmin so that it can be released into the serum. In addition, it can transport copper into the bile so that it can be excreted. So the way I've always pictured this is if you imagine a hepatocyte and it has some copper inside of it, that ATP7B molecule can pick up the copper and it can either transport it out into the bile or it can package it into ceruloplasmin and release it into the bloodstream to be taken away to other organs. Just think of that ATP7B protein as moving the copper all around the hepatocyte. So Wilson's disease occurs when patients are born with a mutation of the ATP7B gene, which is found on chromosome 13. If they don't have a functioning ATP7B transport protein inside of their hepatocytes, then they are unable to excrete copper into the bile. This means copper will accumulate in the liver and it can lead to free radical production and tissue damage in the liver. And as we will see, cirrhosis of the liver is a major feature of Wilson's disease. In addition, all that copper in the liver can spill into the plasma and there will be an increase in the free serum copper level. This copper will then deposit in places like the brain and cornea and also the kidneys and the joints. And as we will see, there are many manifestations of Wilson's disease that occur outside of the liver from deposition of this copper that spills over into the plasma. In addition to problems excreting copper, there will be a lack of ceruloplasmin into the plasma. And a low ceruloplasmin level is a diagnostic hallmark of Wilson's disease. This occurs because, again, you do not have that functioning protein ATP7B, which packages ceruloplasmin and copper and then excretes the ceruloplasmin into the serum. This leads to a quirk in blood testing, which is that the total serum copper level will actually be reduced. And that's because the ceruloplasmin level is so low, and normally ceruloplasmin carries much of the copper. There is, however, still an increase in free serum copper, and that's what leads to many of the manifestations of Wilson's disease. Even though you're born with this condition, it takes years for the copper accumulation and organ damage to occur, so the mean age of symptom onset is 12 to 23 years old. So in a board question, this is going to be a relatively young patient. In the liver, the features are due to cirrhosis, and in addition, these patients have a high risk of progression to hepatocellular carcinoma. They're often screened for development of hepatocellular carcinoma. In the central nervous system, there are characteristic features from deposition of copper in the basal ganglia. I talk about this in more detail in some of the neurology modules. These patients can develop movement symptoms that look like Parkinson's disease. They can have dyskinesia, which is abnormal body movements, and dysarthria, which is abnormal speech. They may develop a tremor, and then they characteristically develop behavioral changes that include dementia and depression. Hemolysis is also often a feature of Wilson's disease. This is related to copper deposition in red blood cells. The exact mechanism is unclear, but it is a Coombs negative hemolytic anemia that can be seen in Wilson's disease. And then finally, there is a finding in the eyes that is diagnostic of Wilson's disease, and that is called the presence of a Kaiser-Fleischer ring. These are corneal copper deposits that occur in a layer of the cornea called Descemet's membrane. They occur at the junction between the cornea and the sclera. It's called the corneoscleral junction, or the limbus of the cornea. If you look at this picture on the screen here, you can see that this patient has a brown rim around the cornea of the eye. I'm drawing my pen through it right now. That brown rim is called a Kaiser-Fleischer ring, and if you see that, it is diagnostic of Wilson's disease. It doesn't occur in anything else. It's seen in half of patients who have Wilson's and have liver disease, and it's seen in 90% of patients who have Wilson's with central nervous system involvement. You can detect very early evidence of Kaiser-Fleischer rings by doing a detailed eye exam called a slit lamp exam. And this is a classic board question to describe a patient who may have Wilson's and ask you what test to order next. Many students will choose a liver function test, but in fact, if you choose an eye exam, you can make the diagnosis by seeing Kaiser-Fleischer rings. So the three characteristic tests that are used for diagnosis are first a low ceruloplasmin level. As I told you before, this is a hallmark of Wilson's disease. A high urinary copper excretion. This is a 24-hour test. You collect the urine and analyze it for the amount of copper. And then finally the slit lamp exam to look for the presence of Kaiser-Fleischer rings. The treatment is a drug called penicillamine. This is the structure of penicillamine shown on the screen here. It binds copper and promotes its excretion in the urine, and this will reduce the exposure of organs in the body to free copper. Now let's move on and talk about our second disorder, hemochromatosis. This disorder is also an autosomal recessive inherited condition, much like Wilson's disease, but in this case, hemochromatosis involves iron metabolism instead of copper, and this is a hunk of iron on the screen here to remind you that iron's the problem in hemochromatosis. Let's start by reviewing the different types of iron we consume in our diet and how they are absorbed. One type of iron we consume in our diet is called heme iron. This is iron that's found inside of a molecule of heme. On the screen here is a picture of the structure of heme. You can see that it's a large molecule made up of carbons, hydrogens, and nitrogens, and in the middle of a molecule of heme is an atom of iron. We consume heme iron in many of the meats that we eat, and it's generally easily absorbed by duodenal epithelial cells, as I've shown in this diagram at the bottom of the screen. The other type of iron we consume in our diet is called non-heme iron. This is iron that is free, and it is best absorbed in the Fe2+ state, and vitamin C helps by converting any Fe3+ iron in our diet into Fe2+ iron, which can then be absorbed by duodenal epithelial cells. There really isn't any major metabolism of iron in the human body. We consume iron in our diet, and the uptake to plasma is regulated by enterocytes, but once the iron gets into our body, there are few mechanisms for excretion. We can get rid of a small amount of iron in sweat and the sloughing of skin and GI cells, and women lose some iron each month when they menstruate, but other than these two minor mechanisms, there is no major pathway by which the body can excrete excess iron. So before we discuss hemochromatosis, let me just review some vocabulary. Ferritin, you may know, is an iron storage protein, and it is found inside of cells and also in the plasma, and this is important because in the workup of iron disorders and certain types of anemia, we measure the serum ferritin level. Hemosiderin is also an iron storage compound. It's made up of clumps of many different types of molecules, including some ferritin, and it is found only inside of cells, often inside of macrophages. You may see hemosiderin on a biopsy specimen, but you are never going to measure a plasma hemosiderin level. Hemosiderosis is the accumulation of hemosiderin inside of cells. This is something that's often described in biopsy specimens when we see the presence of lots of iron in the form of hemosiderin. And then finally, hemochromatosis, which we'll talk about next, is a disease that occurs due to iron accumulation. Hereditary hemochromatosis, as I mentioned before, is usually an autosomal recessive disorder, and I use the word usually because there is a rare form that's autosomal dominant. It is caused by an abnormality in a gene called the HFE gene. The HFE gene gets its name because HFE stands for high iron, the H for high, the Fe for iron. The HFE gene is found in chromosome 6 and it codes for the HFE protein. Most commonly, hereditary hemochromatosis occurs because of a homozygous mutation of the HFE gene called C282Y. This mutation gets its name because it results in a cysteine to tyrosine substitution at amino acid 282 of the HFE protein. Less commonly, patients are heterozygotes. They have one HFE gene with the C282Y mutation, and the other HFE gene has a different mutation called H63D. And both of these mutations are relatively common among Americans, and therefore children are often born with two mutations of their HFE gene that lead to hereditary hemochromatosis. The exact function of the HFE protein in iron absorption is unclear, but what we do know is that when you have a mutation, you develop unregulated iron absorption of both heme and non-heme iron. And as I told you before, there are few mechanisms for excretion of iron from the body, therefore you accumulate iron over the course of your life. The disease usually presents in adulthood because just like with Wilson's disease, it takes several years for the iron accumulation to develop into symptoms. And importantly, women who have hereditary hemochromatosis present later than men, and that's because they menstruate and therefore they lose some iron every month. You can develop hemochromatosis without an abnormal HFE protein if you receive excessive blood transfusions over the course of your life. This is called secondary hemochromatosis. The problem is the same as in hereditary hemochromatosis in that the body cannot excrete excess iron. However, in this case, the excess iron is coming from blood transfusions, not from abnormal absorption in the gut. And this is commonly seen in people who have hematologic disorders that require chronic transfusion therapy. One of the big ones is beta thalassemia major. You can also see this in patients with sickle cell anemia or refractory aplastic anemia, certain types of myelodysplasia, and also some patients with leukemia. There are a number of organs in the body where iron deposits in patients with hemochromatosis. One of the most important is the liver. Patients with hemochromatosis can develop hepatomegaly and abnormal liver function tests. This can progress to cirrhosis, and there is an increased risk of hepatocellular carcinoma in patients who have hemochromatosis. Iron can also deposit in the pancreas, and this can lead to diabetes. It can also deposit in the skin. Iron plus melanin turns the skin bronze, and years ago when there was no treatment for hemochromatosis, it was called bronze diabetes because these patients would be left untreated, their skin would turn bronze, and they would develop diabetes from involvement of the pancreas. In the heart, iron can infiltrate the myocardium in patients with hemochromatosis. This commonly causes a dilated cardiomyopathy where the left ventricular ejection fraction becomes low. You might think that because iron infiltrates the myocardium, this could lead to a restrictive cardiomyopathy, but that only rarely happens. More often, the iron simply disrupts the myocardial fibers, leading to a dilated cardiomyopathy. In the joints, iron deposition can cause arthropathy, and joint pain can be a major problem for patients with hemochromatosis. And then finally, iron often deposits in the pituitary gland, and this leads to decreased release of gonadotropins like LH and FSH. So in men, this will cause the testes to become atrophied, and men who have hemochromatosis can have decreased libido and impotence for this reason. Two special and high-yield features of hemochromatosis to know for step 1. The first is that these patients should never consume alcohol because it accelerates the liver disease of hemochromatosis. And then the second thing to know is that these patients should not take extra vitamin C because that may increase iron absorption. If we go back to this slide, vitamin C converts Fe3 plus iron into Fe2 plus, which can then be absorbed. And you don't want to do this in patients who have hemochromatosis and are absorbing too much iron at baseline. When you do laboratory tests on patients with hemochromatosis, you will see an increased amount of iron and an increased amount of ferritin, that storage form of iron. A normal ferritin level is less than 300, and in patients with hemochromatosis, it can get as high as 1,000. Shown on the screen here is a table of the characteristic iron studies seen in patients with hemochromatosis. Obviously, the iron level will be high. Ferritin will be high because there's lots of storage iron present inside the body. Transferrin is the transport protein for iron. This will be low. The body doesn't want any more iron, so it's lowering its production of transferrin. And then the percent saturation, which is the iron divided by the transferrin, will be high because the iron has gone up and the transferrin has gone down. In the modern era, we usually make the diagnosis by genetic testing. We now have readily available tests for the C282Y mutation. Most patients with hemochromatosis are homozygous, meaning they have 2 copies with the C282Y mutation. And if you find that the patient is homozygous for this mutation, that confirms the diagnosis. If you do an MRI, you will see that the liver turns black in patients with hemochromatosis. This is from the iron deposition. This is called a low signal. Sometimes patients have an MRI for another reason, and incidentally, the liver is identified as being jet black, which suggests hemochromatosis. You can also do a biopsy, usually of the liver. You can use the Prussian blue stain, which will display blue granules from iron deposition. And this is a picture of a liver biopsy specimen. You can see these blue granules throughout the liver from Prussian blue staining, and that's what's seen in hemochromatosis. The treatment for the hereditary form of hemochromatosis is phlebotomy. If you withdraw blood from the patient, as shown in this picture on the screen, you will remove iron stores from their body. And these patients have a normal bone marrow, so they will synthesize red blood cells to replace the red blood cells that you removed, but in the process, you will have pulled some iron out of their body. Usually phlebotomy is repeated every week or so until the ferritin level falls to be within normal limits. There are also drugs that can be used to treat hemochromatosis. These are called iron chelating agents. These are drugs like deferoxamine, deferiprone, and deferasirox. Now, phlebotomy is the preferred therapy for hereditary hemochromatosis. Where these drugs are often used is in secondary hemochromatosis. For example, if the patient has an anemia that requires repeated transfusions, you can't treat that with phlebotomy. The last thing you want to do to an anemic patient is withdraw red blood cells. In patients who are anemic and have hemochromatosis secondarily to blood transfusions, you often want to use these chelation agents. On the other hand, patients who have the hereditary form of hemochromatosis, they have normal bone marrow, they are not anemic, and therefore you can perform phlebotomy at regular intervals to get the iron out of their body. And that concludes our module on Wilson's disease and hemochromatosis.